Welcome to our YouTube channel dedicated to lumbar spondylosis. Here, we aim to provide you with valuable insights into this common degenerative condition of the spine. Join us as we explore the epidemiology, clinical presentation, differential diagnosis, diagnostic procedures, outcome measures, examination techniques, and both non-surgical and surgical medical management options, including the role of physiotherapy. Stay tuned for expert advice and practical information to help you better understand and manage lumbar spondylosis effectively. Spondylosis refers to degenerative conditions affecting the discs, vertebral bodies, and associated joints of the lower back. Low back pain (LBP) is a common condition affecting 60–85% of adults at some point in their lives. Spondylosis, a term used to describe various spinal problems, including spinal stenosis, degenerative spondylolisthesis, osteoarthritis, aging, trauma, and regular wear and tear of the intervertebral discs, vertebrae, and associated joints. Lumbar spondylosis, a complex diagnosis that primarily affects the lower back due to mechanical stress. It is easily identified through radiographic imaging, but its prevalence in all patient populations makes it challenging to diagnose symptomatic cases accurately. Osteophytes, bony outgrowths seen in 85.5% of individuals aged 45–64 years within the lumbar spine, contributing to lumbar spondylosis. Degenerative changes, these can occur in young individuals without any history of trauma and are associated with lumbar spondylosis. Clinically relevant anatomy, spondylosis, or degeneration of the lumbar spine, begins with changes in the intervertebral disc. These changes lead to alterations in the physical properties of elasticity and mechanical resistance. The disc lesions cause pathological changes in the vertebral bodies, resulting in the formation of osteophytes bone spurs. The majority of osteophytes are located in the front or side of the spine, while posterior vertebral osteophytes are less common and rarely cause compression on the spinal cord or nerve roots. Epidemiology, spondylosis is a condition with multiple possible causes and definitions. It affects around 27–37% of people with asymptomatic lower back pain. In the United States, the prevalence of lumbar spondylosis is about 3% in individuals aged 20–29 years, increasing to over 80% in those older than 40 years. Approximately 84% of men and 74% of women have vertebral osteophytes, most commonly at the T9, 10, and L3 levels. In people aged 55–64 years, around 30% of men and 28% of women have lumbar osteophytes. For those aged 45–64 years, approximately 20% of men and 22% of women have lumbar osteophytes. The condition affects both sexes equally. Spondylosis seems to be a non-specific age-related phenomenon. Most international studies indicate no clear links to lifestyle, height, weight, body mass, physical activity, cigarette and alcohol consumption, or reproductive history. Adiposity is considered a risk factor in British populations but not in Japanese populations. The effects of heavy physical activity and its relation to disc degeneration are still controversial. Clinical presentation, patients with lumbar spondylosis experience pain in the central area of their spine. The degenerative changes can affect various structures, including facet joints, intervertebral discs, sacroiliac joints, nerve root dura, and myofascial structures. These change to different clinical presentations, such as spinal stenosis, disc herniation, bulging of the ligamentum flavum, spondylolisthesis, and lumbar radiculopathy. All of these conditions contribute to a combination of pain symptoms known as neurogenic claudication (NC). Neurogenic claudication can involve varying degrees of lower back pain, leg pain, numbness, and motor weakness in the lower extremities. Symptoms worsen with standing and walking and improve when sitting or lying down. Differential diagnosis, When a patient experiences low back pain, there are various potential causes, including 1. Lumbar spondylosis and its subdivisions. 2. Rheumatoid arthritis. 3. Excessive exercise. 4. Ankylosing spondylitis. 5. Coccyx pain. 6. Spinal masses. 7. Infection. 8. Discitis. 9. Lumbar compression fracture. 10. Mechanical low back pain. 11. Overuse injury. Diagnostic procedures. Diagnostic procedures should be reserved for cases with chronic low back pain or when red flags are present. In the acute stage of simple low back pain, a conservative approach involving pain medication and physiotherapy is recommended. Clinical presentation and appropriate objective assessment, including inspections, palpation, and relevant imaging tests MRI, CT scan, and X-ray, should guide the diagnosis. Special provocative tests such as straight leg raise, Faber test, Elias test, Mental test, Stork test, and femoral nerve tension test, along with neurological and neurodynamic assessments, are crucial components of the objective evaluation. Outcome measures, Numeric Pain Rating Scale NPRS, Roland Morris Disability Questionnaire RMDQ, Oswestry Disability Index ODI, Pain Self-Efficacy Questionnaire PSEQ. 1. General examination of the spine. Observe the spine for any noticeable swelling or surgical scars. Check for deformities such as scoliosis, sideways curvature, kyphosis, excessive outward curvature of the upper back, loss of lumbar lordosis, reduced inward curvature of the lower back, or hyperlordosis of the lumbar spine, increased inward curvature of the lower back. Look for any shoulder asymmetry or pelvic tilt. 2. Palpation. Gently touch and feel the spine to detect tenderness over bones and soft tissues. Perform an abdominal examination to identify any masses that could be related to spine issues. Consider a rectal examination to rule out other pathologies in the pelvic region. 3. Movement. Assess the spine's range of motion by asking the patient to perform flexion forward bending, extension backward bending, lateral flexion side bending, and rotation. Additionally, examine the shoulders and hips to ensure symptoms are not originating from these joints. 4. Neurovascular examination. Evaluate sensation, muscle tone, muscle strength, and reflexes to assess the neurological function of the spine. Check all peripheral pulses to ensure proper blood flow, as vascular claudication in the limbs can sometimes mimic symptoms of radiculopathy, nerve root compression, or spinal canal stenosis, narrowing of the spinal canal. Medical management. 1. Non-surgical management. Pharmacology and pain management utilizes medications to alleviate pain and inflammation. Includes over-the-counter pain relievers, example, acetaminophen, NSAIDs, and prescription medications, example, muscle relaxants, opioids, based on the severity of pain. Helps manage pain but may not address the underlying cause. B. Therapeutic corticosteroid injection involves injecting corticosteroids directly into the affected area to reduce inflammation and pain. Typically used for conditions like herniated discs or spinal stenosis. Provides temporary relief, but multiple injections may be needed. C. Lumbar facet joint injections targets the facet joints in the spine, which can be a source of pain. Involves injecting an anesthetic and anti-inflammatory medication into the affected joint. Can help diagnose the source of pain and provide relief for a variable duration. 2. Surgical management. Spinal fusion, commonly performed for chronic nonspecific back pain with degenerative changes. Involves joining two or more vertebrae together to stabilize the spine and limit motion. Can reduce pain but may also restrict flexibility in the fused area. B. Laminectomy, frequently used for lumbar spinal stenosis. Involves removing part of the bone, bone spurs, or ligaments to relieve pressure on spinal nerves. May lead to spinal instability in some cases. E. Disc replacement, involves replacing a damaged or degenerated disc with an artificial one. Preserves motion in the spine while treating disc-related issues. Suitable for select patients who meet specific criteria. F. Interlaminar implant, a minimally invasive option to treat lumbar spinal stenosis. Involves inserting an implant between the vertebrae to stabilize the spine and open up the spinal canal. Provides relief from spinal nerve compression. Physiotherapy Management. 1. Education team, review lumbar anatomy with the patient. Explain the concept of posture and ergonomics. Teach appropriate back exercises to the patient. 2. Manual therapy team, utilize the McKenzie method for lumbar spine management. Provide massage therapy for pain relief. Apply TENS transcutaneous electrical nerve stimulation for pain reduction. Incorporate yoga and Tai Chi exercises for back pain management. Offer back school sessions to educate and prevent future back problems. 3. Modalities team, use lumbar back support to stabilize the spine, correct deformities, and reduce mechanical forces. It may help alleviate pain while sitting. Apply taping standard or kinesia tape to relieve lower back pain. However, taping should be used in conjunction with therapy to improve range of motion. Consider lumbar support braces for stabilization and reducing mechanical forces, although their efficacy is not fully supported by evidence. 4. Bio-psychosocial team, employ a multidisciplinary approach involving various healthcare professionals. Reinforce positive behaviors and modified expectations. Teach imagery relaxation techniques to help manage pain and disability perception. Thank you for joining us on this journey to explore lumbar spondylosis. We hope this video has provided you with a comprehensive understanding of the condition, including its epidemiology, clinical presentation, differential diagnosis, diagnostic procedures, outcome measures, examination techniques, and medical management options. Remember, early diagnosis and a multidisciplinary approach, including physiotherapy, can greatly improve outcomes. Stay informed, stay proactive, and take control of your spinal health. Don't forget to like, comment, and subscribe for more informative content.